We have a panel discussion on ART and preeclampsia. The moderators are Dr. Kamini Rao and Dr. Tarakeshwari. Dr. Kamini Rao is a pioneer in ART. She's a Padma Shri awardee, and for all those who have come from other countries, Padma Shri is the award given by the Government of India for people who have contributed great work in that particular field. She's the Padma Shri awardee, mentor, guide, and a PhD scholar. She's the medical director and the founder member of Medline Academics. Over to Dr. Kamini Rao and Dr. Tarakeshwari. We have heard to her talk just now. Dr. Tarakeshwari is the consultant, lead consultant, HOD, obstetrics and medicine, obstetric medicine, and national coordinator for national board examination webinars at Fernandez Hospital. Over to Dr. Kamini Rao and Dr. Tarakeshwari to lead this panel on ART and pregnancy.
Yeah. Well, let's start with the interesting case discussions. And I'm sure all of you know our panelists, but may I invite Professor Sean Brenneck onto the dais, and he's, can I go back to the slide? Yes. Okay. Yeah. He's from Australia, and his areas of interest has been basic and clinical aspects of human pregnancy and its complications. We go to the next one, and we have our very own Shubha Ramarao, and she is our president of BSOG, has been working in this area of pregnancy complications, and a DNB teacher, guide, and examiner, and the vice president of the PMS, and a faculty at national and international conferences. Then we have with us Dr. Vikas Satvik. He is the vice president and the academic head of Motherhood Hospitals, and a Rotary Club Award for help in COVID, and of course a Royal College tutor for London and Cambridge. Yes. And we have our very own rock star, Dr. Chandrasekhar. Is he here? No? I always called him a rock star because of his hairstyle, but he's not here. He is actually heading Chandri, actually works on immunology in pregnancy. He's done yeoman service, but I don't know he's here. He's not here. Okay, then the next person. Okay, so we have Dr. Prakash, who his areas of interest has been in fetal growth restriction and basic fetal genetic counseling. Okay, and then we have our own Dr. Divishri, who has been one of our consultants in IVF, and she's done her fellowship in reproductive medicine and also an expert in reproductive endocrinology, and a consultant and director of Genius Fertility Center. So with this, I think we have the entire team completed. So my colleague, Dr. Tarakeshwari, now will take over with the first case.
Thank you, ma'am. So let us go into the case scenario 1. We have Mrs. B, 37-year-old homemaker, wife of Mrs. T, 41-year-old businessman. She's married in 2011. It's a non-consanguineous marriage. Her cycles were regular. Her BMI is 40. And her obstetric history, the first pregnancy in 2022 was a spontaneous conception, uneventful antenatal period. She had a cesarean section done at 38 weeks in view of oligohydramnios. Girl baby 3.2 kg, 11 healthy. No intra-op or post-operative complications. The second pregnancy is the present pregnancy, IVF conception. It is frozen embryo transfer. At 5 weeks, the random blood sugar was 208 milligram per deciliter. Sorry for the mistakes. Diagnosed with type 2 diabetes mellitus. She was started on medical nutrition therapy and oral hyperglycemic agents. At 5 weeks also, she was found to have a raised blood pressure and was started on telmisartan, 40 milligram once daily. She stopped all medications within a week as she had diarrhea, and a scan at 7 weeks showed twin gestation. With the twin A, the CRL was noted, and twin 2, there is no fetal pole. She's booked at 9 plus weeks to us. She was referred to us at this period of pregnancy. So can I ask the question to Dr. Sean? How often you come across women with undetected medical disorders like diabetes, hypertension in your practice? And the next question would be, after you answer that, which method do you prefer, a fresh or a frozen embryo transfer? What difference do they have in relation to preeclampsia risk development? Over to you, Prof.
In terms of how often might I come across women with undetected medical disorders like diabetes, hypertension in my practice, I have the good fortune to work in a tertiary referral hospital in an MFM service. And so it would be uncommon for me to discover these sorts of comorbidities that usually have been found and be described in the referral letter. In terms of the method I would prefer, I acknowledge I don't practice ART myself. I'm an obstetrician, but I would advise my ART colleagues that a fresh embryo transfer would be less likely to develop problems like preeclampsia in pregnancy. There's good evidence for that. And that is the answer to the third question as well. And if I was, again, bold enough to offer my ART colleagues some advice, it would be a single embryo transfer would be a much wiser decision in terms of minimizing the likelihood of subsequent adverse outcomes, including preeclampsia especially.
Can I ask this question to Divishri? Why would you want fresh transfers to frozen transfers, Divishri? Why is the incidence of preeclampsia higher in frozen transfers?
This is more dependent on the presence or absence of corpus luteum. So, in my practice, it is not that I do freeze all or fresh transfers for all. It is always an individualized approach. When I have just, very less number of eggs, probably for a poor responder, and I just have 2 corpora lutea, I would rather prefer and do a fresh embryo transfer, so that probably 1 corpus luteal deficiency can be made over by 2. But if it is a case of OHSS or she has got multiple number of eggs, I would rather go for a freeze-all protocol. And in case of frozen embryo transfer versus mild stimulation protocol transfers or a natural cycle, I would, as the evidence also suggests, natural cycle FETs are much better because we have the, rescuer, the corpus luteum, which is very important, not just as a hormone factory, but probably also immunomodulator in terms of the hormones which it releases, like relaxin, estrogen, progesterone. So it is more like a natural pregnancy. So I would always individualize approach, and I would not always go for a freeze-all protocol or a fresh embryo transfer as well. But yes, I would prefer to do an embryo transfer when there is a corpus luteum.
But because of the current scenarios that we see, that more people are actually preferring frozen transfers to fresh transfers, to those people, what would your take-home message be?
As you have always taught us, madam, that one size does not fit all. We always have to individualize, and we cannot set protocols like, okay, it has to be always freeze all. We always have to individualize and see what are the risk factors, only then to decide. It does not come as an algorithm. As doctors, we are always used to algorithms, A plus B, and then it should be C. No, it doesn't work like that, at least in IVF. So always go for an individualization, and definitely no fresh transfer when she's at risk of OHSS, because OHSS itself is an independent risk factor for preeclampsia. And if possible, try and do, especially if she's an advanced maternal age patient, try and do an embryo transfer when there is a corpus luteum. But nevertheless, we cannot always do this protocol in women who are premature ovarian failure, in women who are PCO, who don't have ovulation. In those patients, we have to resort to HRT, and we don't have any other option.
And what about the third question there, Professor Sean? What difference do they have in relation to preeclampsia risk in development in this particular women who have diabetes, hypertension in practice? In relation to the first question, the third question.
Well, clearly, because of her relatively advanced maternal age and the comorbidities of diabetes and hypertension, she is clearly at an increased risk of preeclampsia. Couple that with the fact that she's required ART, which generally is called assisted reproductive technology, but I call it artificial reproductive technology because that's what it is. And I think that is part of the reason why there intrinsically are increased risks associated with the outcomes of ART pregnancies. And if she did have a frozen embryo transfer, that adds to the risk of preeclampsia. The data is clear on that.
Yeah. Would you think that because of the diabetes and the hypertension that is there, that would actually work on the vasculature, and that could be one of the reasons why the incidence of preeclampsia would be higher in the those kind of premorbid conditions in the women that had diabetes and hypertension?
Most of the data that is available to answer that question is retrospective, and there has often been a lack of control for the confounders like comorbidity. So it's not a crystal clear answer, but I think if you're weighting the proportions that contribute to the increased risk of preeclampsia, the first one I'd pick is the multiple pregnancy. She has a twin pregnancy, although, as it happens, one of the fetuses has passed by the earlier slide, I think. But the combination of her age, her diabetes, her chronic hypertension, and the fact that she's requiring ART for the pregnancy in total gives her a significant increased risk of preeclampsia.
So
thank you, Prof. So assisted reproductive technology, advanced maternal age, diabetes, hypertension, everything. She has at a risk of superimposed preeclampsia. So the baseline investigations done were hemoglobin was 11, the platelets were normal, and we always do a HB variant analysis at booking to rule out the trait, to know the hemoglobinopathies, and then we check the partner. And the HbA1c is 7.1. Obviously, her random blood sugar was 208 at booking. Her creatinine is 0.6. And the scan showed a single life of 9+ weeks with second empty gestational sac. Dr. Shubha, how do you counsel this mother since her HbA1c is 7.1? And also the comment on the antihypertensive given at 5 weeks of gestational age. Is it safe and what is the drug of choice if you'd like to change?
One thing is, this patient at 5 weeks was predicted to have very high sugars when, embryo transfer was done just 5 weeks back. So if I'm given to understand, she would have been worked up then, right? So she would have been a borderline diabetic, and the moment she has conceived, it's become very frank, and it is, the sugars are very high. So HbA1c of 7.1 definitely increases the risk of 2, 3 things. One is that, 7 and under, how I would counsel her, 7 and under, the relative risk of fetal anomalies is less, but she has an age-related risk of aneuploidies itself. And 7.1 to 7.4, her risk increases to about 3 to 7% of having fetal anomalies, as well as, the age-related risk of aneuploidies will increase the risk. However, I would counsel her by saying that, the risk is very relative, and nowadays we have all modalities to detect these problems, and therefore I wouldn't scare her, but I would encourage her to start a nutrition therapy, she will probably definitely need some insulin and also antihypertensives. And the safer antihypertensive would be alpha-methyl-dopa or labetalol, rather than giving losartan, that is telmisartan, which is not recommended in pregnancy at all. So we would change that. I would take a multidisciplinary approach, send her to an endocrinologist or a diabetologist, and control all her problems and encourage her to do testing at the correct time, so that we'll pick up problems as time passes. The other thing I would tell her is that the uterine milieu is very important for the baby, because in utero onset of adult disease is one thing which I would emphasize upon her, so that she is more concerned for the baby. She may say it's all right, I am not as long as I'm feeling okay, it's okay, but no, she has to be completely normal for her baby. So that would encourage her to follow MNT, and most important, her BMI is 40, I thought you said. So even whatever it is, 5 minutes of exercise, 10 minutes of exercise at an hour after her meal, all that is going to add to her success of her pregnancy, as well as the future of the baby which is growing in utero. So I would counsel her like this, not scare her, but encourage her to follow all the norms, have a regular checkup, because she misses a NT scan and comes at 16 weeks again with sugars of 400 is not good for the pregnancy at all.
Thank you, ma'am, for the clear and the loud message. There is no role for any termination. That is
Yes,
what
definitely
actually
no role.
you have explained. Don't scare her. There is a modality to look at the abnormalities. We have a first trimester fetal health check. And this is a real life scenario which was referred to us last week before I started preparing for the conference. I have taken the 2 live cases actually who came to our clinic.
So in fact, even with the HbA1c of 12 or so, when the risk increases to 20, and some literature has said 45% also, yet the other 45%, 55 would be normal. So it is like looking at half glass empty or half glass full. So we have to encourage her, because that's the best chance. She's 37 years, and it is an IVF pregnancy. So we have to do the best for her to have this pregnancy.
Any mother coming with such a scenario, we don't have to scare her. That is a very clear, loud message. Yes, she had a nutritionist and an endocrinology review. She was started on insulin therapy. The retinopathy screening was normal. She started on low-dose aspirin. In view of chronic hypertension, she was advised home BP monitoring. That time, she was not requiring any medication over the next few days. And creatinine, electrolytes, ECG, and the 2D echo were normal. So in view... She had a low TSH at that particular time, and it was repeated, and a transient gestational thyrotoxicosis was considered. A repeat T3, T4 TSH after a week also showed a persisted low TSH. 3 T4 was raised. TSH receptor antibodies were found to be high. She had a weight loss of 5 kgs in 8 weeks, and she was started on methimazole, considering the thyrotoxicosis as the diagnosis. Immunologist Dr. Chandrasekhar is not here. So the low TSH in the first trimester, don't panic, repeat it. Very rarely we come across such scenario where we need to start the medication. Endocrinologist help was taken here. Opinion was taken here. So the fetus, the first trimester screening was done, low risk for aneuploidies. She was screened positive for preeclampsia, and the low dose aspirin dose has become 150 milligram once daily. So suppose this mother comes, do you directly start 150 milligram? This question is to the obstetricians. Or you start with the guidelines of 75 milligram and later increase it to 150 milligram.
I think in this case, I would start with 150.
Yeah, very clearly.
She has all risk factors, her age, everything, even though her previous pregnancy was quite all right, right? She's a previous cesarean. I would also take history of, maternal family history of whether, she herself was, mother had any problems, hypertensives and things like that. But I would definitely start 150.
Because there was extensive discussion on screening yesterday and today. Nice guidelines, pre-gestation diabetes, 75 milligram is what the recommendation is. But now the recommendation is 100 milligram can be started. But as you said, 150 milligram, we could have started earlier. And this is the first trimester, enhanced first trimester screening, which is fine. And then the preeclampsia risk, as I told, is 1 in 84, and the fetal growth restriction is 1 in 27. So, Dr. Prakash, what effects on the fetus would you specifically look for because she's on methimazole, and any other things you want to add on for the first trimester scanning?
Methimazole is normally not started in the first 3 months because it has a tendency to cross the placenta and has an effect on the growing fetus. So in the first 3 months, propyl thiouracil is better, but because of it causes hepatotoxicity, after the 3rd month, it is generally methimazole which is started. As far as the effects of methimazole, the direct causal effect of methimazole are only aplasia cutis is one. The other is choanal atresia. So these two have known to have direct causal effects. But other than that, it has got a association which has not been proven as said with statistics, but then it does cause esophageal atresia. It does cause some amount of gastroschisis and a set of renal abnormalities as well. Some literature do mention cardiac abnormalities also, but these are not statistically significant. As far as how do we monitor those things on the scanning? One thing we can always look at is whether there is a thyromegaly in the growing fetus, which is something we don't tend to see anything in the neck region which is quite abnormal. So a thyromegaly in the fetus will tend to stand out quite clearly. So that is one. And because we have two causal, this one we'll have to look for the esophagus properly, and it will document the stomach is seen, because esophageal atresia is something which is known. And also look for the scalp in general. And of course look for the, the gastroschisis. So as far as methimazole is concerned, these are the major things which we do.
This lady was started after 12 weeks only because they wanted to confirm low TSH, and that was repeated again, and she had a significant weight loss with anti-thyroid antibodies also being elevated. So after the 12 weeks only this was started.
And one more thing we can just look at is whether the mother was a Graves disease, because the Graves antibody tends to cross the placenta. So that is also something we should keep in mind in this.
So how would you counsel the mother when you're doing the scan? If she says, will my baby be normal? I mean, what kind of counseling, guarded counseling will you give the mother?
Methimazole, even after 12 weeks, can have some amount of placental transmission and effect on the fetal thyroid. So we do tell them that we'll have to monitor it over a period of time. And the baby immediately after born will have to be checked for the neonatal thyroid levels. So that is something which we'll have to tell them. But we'll have to tell them this is essential because of maternal condition. We'll have to continue on the medication. But then, yes, there is a subtle, mild chance that the baby can be affected. And ruling out that the major anomalies are not there, we say baby is growing fine. There is no thyromegaly. So let us just, only thing we'll have to be on a watch. And then after neonatal, we do check it.
Would you think of an intracord blood to see whether the thyroid in the fetus is normal or not?
Not that it's recommended anywhere.
No,
No, ma'am.
because of the antibodies.
Yes, ma'am. Not only that, why invasive when we're not seeing anything which is grossly abnormal, and to cause an invasive testing for this is not yet been
Not
recommended.
required. Okay.
So to summarize, this lady is second gravida, previous cesarean section, ART conception. Started with twin pregnancy with empty gestational sac. She had detected to have diabetes and hypertension in the first trimester. She finished her enhanced first trimester screening. Added problem was thyrotoxicosis, and yes, she is morbid obesity. Right now, she is at 14 weeks of gestation. As summarized, you look for the fetal thyroid, and she will wait for the anomaly scan. And if she develops any fetal thyroid, then the invasive procedure, as Dr. Kamini has said, further management with the fetal cord blood sampling. If we find a goiter.
If there's an abnormality, not as a routine screening.
Yes.
Yeah, let's put the second.
So we are going to the next case scenario.
So we have now Mrs. P, who is a 37-year-old graduate homemaker and wife of Mr. A, 38-year-old IT employee. Married in 2016, non-consanguineous, and of course irregular cycles, and no case of PCOS, and was on metformin. BMI is 34. Dr. Shubha, how do you evaluate her for fertility? And what is your recommendation for morbid obese mothers in pre-pregnancy counseling?
Yeah. Again, she's 37-year-old, with a BMI of 34. And also she's been diagnosed as PCOS, and she's been having irregular cycles. So, and she has been married for something like 6 years or something, right? Yeah. So she needs a complete evaluation to begin with, and of course, counseling. First thing is the fact that she has irregular cycles, has been diagnosed PCOS, and her BMI is more. I would like to find out, apart from her family history, a good clinical examination wherein I would look at evidence of acanthosis, if there is, whether she has hirsutes, whether she is having any acne at present, and of course the type of obesity that she is having. So having evaluated that, and of course a thorough family history, because if the parents are diabetic and she is obese, she PCOS with acanthosis, is a very high percent that her sugars are going to be normal. So I would look at her clinically, take a proper history, and then decide on a few tests. Like if she has never done any tests, I would like to do a complete evaluation along with her TSH, HbA1c, and blood sugars fasting postprandial. Also, I would like to do a lipid profile because she is prone to everything. And I would like to know if she was having regular cycles when she was on metformin, because that's one thing which, if her cycles were regularized on metformin because of its action on the sex hormone binding globulin and things like that, they do sometimes ovulate by themselves when they are in metformin. So the other thing I would like to find out is whether her weight gain has been recent or she has always been, since menarche, she has put on weight suddenly. Because if she she has put on. If she has put on weight now, suddenly, one thing is whether it was after stopping her metformin or whether a new problem like hypothyroid status has set in. So I'd like to do a complete lipid profile. I mean, apart from the routine, her TSH, lipid profile, and counsel her accordingly. So and I would also tell her that even if she loses about 5 to 10% of her weight, her cycles may get regularized. She will respond better to infertility treatment, and the outcome of her pregnancy is going to be good. So she has to start from day one. I'll put her on, I'll send her to a nutritionist or dietitian. I would ask her to do exercise, whatever. Apart from the exercise, she also needs to, have some meditation and yoga practices, which is going to bring down the stress. I'm sure she is a stressed lady, and therefore stress will increase the stress hormones in her this thing, and will, and she could be depressed also because of a PCOS, because of the endogenous increase in the testosterone level. And I would take a holistic approach and ask for the necessary tests. Since I suppose she has not undergone any tests, I would like to do a complete evaluation before and counsel her before putting her onto any infertility
What about
treatment.
fasting insulin levels?
The recent guidelines, the society, the international society does not recommend insulin levels, neither androgen levels for diagnosis of PCOS. It's a clinical diagnosis, and also when you do a scan, the morphology of the ovaries, and in her case, I would typically do AMH and look at the antral follicular count evaluation of her infertility.
And if you were to ask her to lose weight, what kind of counseling would you do to these people? Because I've seen that many times doctors try to get them to lose weight, but I find that there is a lot of resistance from these women. They change the doctor, but not the weight. And I would like to ask Vikas, if you can tell us any other secrets, because running a large chain of motherhood, you will be able to have some tricks up your sleeve. Because this is a very important question that I want to put across the audience. It sounds simple, just take the fat off, but it's a very important point.
No, ma'am, very well said, actually. They might as well change the doctor than change the weight. We do have, and I have my obstetric colleagues always talk about this, and they find it very difficult. But what we have in the discussions, especially when they call in for antenatal counseling, and especially the precious ones, previous miscarriages or previous losses are there. The discussion usually hinges on what is preventing them, or what is their idea. What is that is making them not lose weight, or what is that is preventing them from being healthy. So what we usually try to sit and do is have more of not an individualistic approach, but more of we don't want to try to corner these patients cornered, but more of trying to sit and understand the issue rather than give advice, because it's very easy for us sometimes as doctors, you do this, you do this, you do this. Whereas the agenda is something else with the patient. They may not even be forthcoming in the first, your meeting. So probably meeting over a period of time, trying to understand the problems, trying to understand why they are not able to do something which is good for them, which is sometimes very difficult to understand. You're telling them the good thing, but they're not trying to understand or do it. Is what makes it different. So what we have found is multiple sessions trying to understand the problems, and sometimes we even use you will not believe, sometimes we have used the GRE sitting outside in the clinics to actually have a casual chat with them. Sometimes they give valuable information as to what is actually happening in the family or in the background. I think that really helps, rather than just bombarding them with do this and giving them outright guidelines.
Can I add something? Yeah. Here I would, call in the husband and not the mother or the mother-in-law who normally accompanies the lady. So I'd call in the husband and have a look at him. I said this in some other fora where if he is obese, I can't ask her to lose weight without him also. So I tell them both of you have to go for a walk, and you don't have to cook separately for yourself and for him. So in general, for everyone, what is good for the family will be good for her in relation to diabetes, hypertension, obesity. So, family has to get together and they have to do it for her. And small steps. She can't lose 10 kgs in a month. She can maybe lose 1 kg in a month. So that is where, small steps she has to take. But not only for her fertility issue, but in general for her whole life is very important that she loses weight. So that is how I would encourage her. But the infertility treatment can go on side by side. Because at 37, I don't want to waste any of her time too. So I would encourage her to do everything together.
Yeah, thank you. A small correction, 30 is mild obesity, 35 is moderate, and 40 is morbid obesity. We started a body positive clinic because as all the speakers, faculty has spoken here, they feel so inadequate when they sit in the antenatal clinic. A body positive clinic is a dedicated obstetrician catering to the women above 40 BMI with a nutritionist, a physiotherapist, and the ultrasound scan will be done in the same sitting. So the results are very good. Our obesity now is 32% at Fernandez. And morbid obesity, more than 40 BMI, is 12%. Over the last 5 years, there is a tremendous increase. Just wanted to add to that, ma'am. Yeah, ma'am. Case continue.
I think, the reason I spent a couple of minutes extra on the obesity is because these people are already within themselves depressed. So the moment they would have gone to 4 doctors, the first thing they would have said is lose weight and then come to me. So they would have come to you as, say, maybe the 5th doctor. And you also bombard them on that very sensitive topic. So you talk to them that we are going to do your infertility. It's not that we are not going to do. You give them some of those, antioxidants, whatever it is. But then say, well, it would be nice if you lose weight and, you lose weight along with your husband. And, there are people, of course, they're very fastidious about their weight. And I want to ask for a last word to Divyashree, because she's so fastidious about her weight that even if there is 1 milligram excess, she's on the treadmill. How do you motivate yourself?
Ma'am, first, regarding this question, it's a very practical question that, it's very easy to say, yes, lose weight, but it is very difficult to do. As you rightly said, these women are already depressed and everyone telling them the same thing. But one small thing, what as a doctor we should do is to appreciate them whenever they lose that little inch loss or there is weight loss, appreciate and then record their weight. All the other things, all the panelists have already told. Yeah, and self-motivate that it has to come from within, but appreciate them whenever there is weight loss, and also relate these things, the weight loss things, to what is the medical benefit that she's going to get, not just with the fertility treatment. It is just about, as all of us were speaking about, in utero fetal programming. With obesity, a lot of in utero problems will start with the baby. So tell her that what is the problem with obesity in pregnancy and even pre-pregnancy. What happens when we give her injections? For example, when we give her gonadotropins, the first thing where the gonadotropins are going to go or get sequestered is in the fat. From there, it is going to go to the target ovary. So when there is more fat, so you need more gonadotropins. More gonadotropins, your cost of IVF or IUI is going to increase. So even 5 to 10% weight loss will make a tremendous difference in how they're going to respond to stimulation. So these are the things that we need to tell them and motivate them, and most importantly, appreciate them whenever there is a small weight loss.
She then brings a nice photograph of her family. 3 of her eldest sisters are even fatter than her with 3 children. She says, my 3 sisters are fat, they produce 3 children. I am the 3rd sister. Why are you telling me when they are saying that we are fatter than you, and you tell your doctor we are in the same family, they are fat, and my mother was fat, my grandmother was fat, so I'm fat. Now you treat me like this. So she has a very positive attitude. So I tell her that so what if your mother is fat and your grandmother is fat, your 3 sisters are fat, because 2 wrongs don't make a right, 5 wrongs don't make a right. Let them all reduce and you also reduce. So all of you go for a walk.
Ma'am, if I may add, as a person who's trying to reduce weight, as a person who's trying to reduce my weight,
yes,
a 200-gram reduction on the screen is heavily motivating. A 200-gram reduction in the scales is heavily motivating.
That's good, because they try all tricks. Okay, so let's get on with this now. I think this chronic hypertension, when evaluated for this primary infertility, she had a creatinine of 0.6, and of course the electrolytes were normal, ECG normal. The labetalol was started with 100 milligrams twice daily. HbA1c was 6.8. And fasting blood sugars 103. Then, of course, you had the PLBS 121. Metformin was continued and was advised MNT. Hypothyroid and was started on thyroxine as per the TSH. So we have now, instead of Chandrasekhar, we will have now Dr. Professor, we have Professor Sean to let us know how often you get referrals for these comorbid conditions and how do you help such women in pre-pregnancy. Go back to that.
So we have, as running up
Professor Sean, can you hold the mic closer to you?
yes.
Then
Is that better?
they can
Thank
hear.
So, ideally, pre-pregnancy, you would, in my hospital, enlist the assistance of an obstetric medicine physician to optimize the medical comorbidities this patient has before you commence any antenatal care.
So, this was the lady then. She's primigravida, conceived with her first cycle of IVF, and was started on insulin from the 10th week of gestation. And MNT was continued with the advice of home blood sugar monitoring. Fundoscopy showed low retinopathy. And of course, the TBA labetalol 100 milligrams twice daily was continued. And here ecosprin was given 75 milligrams, was started after viability. Thyroxine was continued as per the TSH levels. And here are the basic investigations, baseline investigations. Most of them were normal here. And we have now for Sean, is the risk of hypertensive disorders higher in ART than spontaneous conceptions? I think you've answered that there is a slight increase. But the second question is the risk higher in donor oocyte pregnancies? And how do you monitor these mothers?
So clearly, the evidence is again sound that
Can you speak louder, sir?
there is a clear body of evidence to suggest that the risk of preeclampsia will be higher in a donor oocyte pregnancy, 4 times higher than control in the studies that have been reported in the literature. In terms of monitoring these mothers, well, ideally, you would offer her the Fetal Medicine Foundation screening at the end of the first trimester, and in anticipation of the result being high for a risk of subsequent preeclampsia later in pregnancy, I would offer low-dose aspirin, 150 milligrams, to be taken at night, and once she reached 20 weeks gestation in my hospital, I would begin serial S/PLGF ratio estimations. If the initial one was low, then the next one will be done in 4 weeks' time. But if there was a high result, I would increase the frequency of monitoring of the S/PLGF ratio to, say, fortnightly, depending on the delta change in the levels. If it was a rapid increase in the S/PLGF ratio, it might become a weekly repeat test. And once the S/PLGF ratio was showing a significant increase, the monitoring in terms of antenatal surveillance, which might initially be more frequent outpatient visits, would become potentially in due course an inpatient situation for intensive monitoring. But I'm perhaps leaping ahead to the pregnancy situations, but that's the approach I would anticipate using.
Thank you.
So, I think it's definitely proven that when you take donor egg pregnancy, If you look at the odds ratio here of 4.5 with a 95% confidence interval, it shows that there is an increase in preeclampsia with donor egg cycles. And therefore, these people have to be monitored very carefully in assisted reproduction. Let's go to the next slide. So, the meta analysis revealed that IVF ICSI at higher odds of the hypertension and preeclampsia, and therefore, and they are especially high in frozen embryo transfer and oocyte transfer pregnancy. So we have to be careful when you're looking at fresh transfers and natural cycles. You'll find that the chances of hypertension is much lower. So she had regular antenatal follow-ups in conjunction with the physician, nutritionist, and the endocrinologist. Mild anemia was corrected with oral iron. Minimum preeclampsia profile was repeated every 4 weeks. The platelet count, creatinine, LDH, SGPT, and urine for albumin. The flu vaccine of 1 dose, the tetanus toxoid, and the TDAP received. Prakash, what is the screening protocol in the first trimester, and how do you monitor the fetus?
The screening protocol is the same as in non-ART patients, wherein in the first trimester during the NT scan is the time when we start monitoring for the various things. First is we screen for the aneuploidy, then we screen for the morphology is also screened at this point in today's time. But as far as the PIH is concerned, we start with the uterine artery Doppler. But uterine artery, before that, we have to ensure that the maternal BP is monitored and the BMI is also monitored. So the uterine artery Doppler, along with the maternal mean arterial pressure of both the limbs, that is the right and the left upper limb, is measured. And then we put it into the FMF software to have a particular risk factor of preeclampsia. This is what is done on the sonological side. On the biochemical aspect, what we normally do is the double marker, which will give a PAP-A component alone. But in today's time, we can also add the PLGF, which has got a very good, it is proven to be very effective in predicting preeclampsia in the first trimester. So as far as how will we monitor, if there is a high risk of preeclampsia, then we'll be starting them on the aspirin at 150, if not started. Otherwise, we can monitor them using the SFLT after the 20th week onwards, wherein if the ratio of SFLT to PLGF is greater than 85, then it gives us that a standard up to 4 weeks that there is no risk of preeclampsia.
The preeclampsia screens that you recommended in the previous slide, I think there is no doubt the S-bit-field ratio is a superior test and of a similar cost to doing that mini preeclampsia screen. None of those factors are predictive, but the S-bit-field ratio is. So you would only ever need to do the mini preeclampsia screen if you actually had a positive S-bit-field ratio test and were looking to assess the degree of preeclampsia the patient was suffering.
So, well taken, Professor. He means to say SFLT, PLGF, if you use it, you don't have to repeat the investigations every 4 weeks, but we have not yet started PROP at a place where we work at Fernandez, a tertiary referral care center, because it's not that really available, and the costing is one which we are working it out on. How many in the audience are doing SFLT, PLGF? And if you do it, how often, and is it cost effective, and what is your experience? How many mothers you have done?
I agree to Professor Sean. Biomarkers are definitely helpful in prognosticating the pregnancy with hypertensive disorders of pregnancy. And as you rightly said, sir, most of the most of the biochemical tests, which you said that the mini preeclampsia screen, which we will have to repeat frequently, will not be required if we do at least one SFLT-PLGF ratio. And also, sir, like what you told was ulta. Like SFLT-PLGF ratio of more than 85 has a high risk for maternal risk factor adverse effects. Less than 85 is the intermediate risk. Less than 35, low risk for developing complications. So SFLT-PLGF is a biomarker. We did our robust study, which has got published in International Journal of Hypertension in Pregnancy. And we definitely saw that biomarkers have a very good negative predictive value. So if the SFLT-PLGF ratio is less than 35, the likelihood chance for the mother to develop any kind of adverse maternal complication is almost nil in the next
Yes.
7 days.
So we want to know how many of incorporated in the clinical practice here in the audience. Can you please raise your hands?
We will have a
Theoretical
biomarker.
assessment is 100%, yes, but in the clinical practice, how many of you are doing it regularly? So when we don't have not yet started regularly, there should be some way of monitoring. And well taken, Professor, as you said, fortnightly and then weekly, yes, we have to do the cost effectiveness and start doing. Yes, over to you.
Of course, I haven't done or we don't do these split and ratios. But going retro, okay, the basic pathology, what we are bothered about here is for preeclampsia, right? So the basic pathology in preeclampsia is a segmental vasospasm. And this manifests as platelet aggregation and decrease in platelet count. So I was just wondering, why not just keep doing platelet counts, which is not going to cost us as much, and monitor as to what is happening?
Individual guidelines, ma'am, as per the institutions, but the best way is SFLT-PLGF. Over to you, Prof.
We have done a study in our hospital comparing platelet counts, proteinuria, liver enzymes, and the S-split-PLGF ratio test as predictors of preeclampsia. Platelets do not predict preeclampsia. Yes, they'll be low if you've got preeclampsia, particularly the HELP syndrome variant, but they're not predictive, nor are liver enzymes. Proteinuria would be better than the other two, but S-split-PLGF ratio is far ahead of any other predictive biochemical test.
Thank you. So that is the best, but the facility.
Why not just use the PLGF alone?
That is in the first trimester only. But say after that, you should have an SFLT-PLGF ratio, which is more sensitive, more predictable. And if it is negative, then you're not worried. So going back to the... Sorry? We have not started, ma'am. That's what I have put it here. We use in the first trimester screening. We have PLGF incorporated in the first trimester screening, but later on we monitor the clinical and the blood pressure and how the mother is doing and the fetal growth. So we have one trimester, the values we do have. Suppose there is an alteration in the blood pressure, then we repeat this mini PE profile. We reduce, tailor-made it only to those 4 tests, and we do it once, depending upon the blood pressure, we repeat it 2 weeks or weekly.
The thing I thought was, if you're doing ultrasound monitoring and you find IUGR setting in, but the mother's blood pressures are normal, then if you do a split, it will predict that she may develop preeclampsia in the next 2 to 3 weeks.
Yeah.
Otherwise, if it is normal, you could be a little relaxed as an obstetrician, and IUGR may be some other cause.
Yeah, this is an institutional guideline which every institute have to have their own. Right now, we are contemplating to do it. I'm just proceeding with the case because of lack of time. Yes, ma'am.
I think we started it way back. I think, Sneha, it must have been 2019 or so that we started doing this. It was when Revati was asking me, I said, go ahead, we should be doing it. And we were really surprised with the results. And then we went on with this. Now that has become part of the routine in our center. And I find, Revati, would you like to put some comment on that?
The discussion, Revati, is on biomarkers, which I'm telling we have not yet started SFLT PLGF doing it in our hospital.
Yes, ma'am.
That's what we can do it. The theoretical assessment, talking doing, everything is going on, but real life scenario, clinical practice, how many are doing? Nobody has raised their hand.
Sure. So yes, I mean, we started doing this in 2015 precisely. And we actually published this study in 2019, 2020. It's called the Robust Study, where we actually monitored patients with SPIT1-PLGF ratio. What we did was we actually identified all women, singleton pregnancies, any kind of hypotension, 28 weeks and beyond. So it was a very extremely new concept. So it was very difficult to counsel them. So we kind of monitored them serially every 2 weeks and identified who had a value of, say, less than 38 or say 38 and 85 and more than 85. So what we were able to do is when the ratio was less than 38, because we had some historical studies to support this, and we could send these women home, and suppose somebody had a value of more than 85, we intensified surveillance. So we probably put them into the hospital or shifted them to a tertiary place with ICU and blood products. So what the biomarker can do is definitely help you prepare to manage a patient better. It's not that we can completely prevent preeclampsia, we can postpone it, or maybe you can probably manage the patient in such a way that probably she would not go into DIC and the baby would not have IUD. See, we still continue to do this test in Bangalore. I think Milan was the first, we did this research study there, but currently we have been doing it in small pockets. So, and there have been a lot of patients, even from the rural area, who have actually come to us for second opinion because they didn't want to be delivered at 28 weeks because NICU is a costly affair. So it is being done, but I think the awareness should build on.
That's what is the message we wanted to convey. Thank you, Resi.
Yeah. So now with the fetus, the routine things have been done. NT scan shows a low risk for aneuploidies. Then the non-invasive prenatal testing in view of the AMA, low risk. And all the serial growth scans in 28 weeks in view of risk factors showed an average for gestational age baby with normal LICA, and weekly NSTs also was done from the 34 weeks. So here are all the graphs that you see. They're within the normal range. And the primary gravity, 37 years, IVF conception, chronic hypertension, on treatment, type 2 diabetes with well-controlled sugars, hypothyroid, corrected anemia, presently 37 weeks with average for gestational age baby and normal LICA. Plan for induction of baby. So, Dr. Sean and Dr. Shiva, consent for induction of labor, methods of induction of labor, and the intrapartum monitoring. I'd like both of you to comment on that.
Yeah, I mean, definitely she has, I would like to induce labor now because there's no point in waiting any further because the risk of complications are going to increase. So that is how I'm going to counsel her because waiting, though it's an average size baby and the LICA is good, that means the placental function is still okay. And I'm sure Doppler would have been done, which would have said everything is normal. But I definitely would like to, induce her. So, would counsel her against the risk of, for the risk of waiting and the benefits of induction. Of course, there may be a slightly increased risk of a cesarean section, but the fact that she's 37 weeks, IVF pregnancy with so many comorbidities, being in an institution, I may not do an elective section, but I would definitely induce labor. I would take consent and induce labor.
I'm going to be controversial and say that I would do another split-PLGF ratio. And if it was less than 38, I would let the pregnancy continue, assuming the mother was comfortable with that plan. Because if it's less than 38, she's not going to run into problems over the next few weeks.
So, Devisha, can I ask you this question? Being a reproductive medicine expert, but having been an obstetrician before that, at 37 weeks when you want to deliver her. When you commit to an induction of labor, you commit to a cesarean section. So how do you counsel this person when you get into this? Your threshold for a cesarean will be much lower, obviously, but how would you counsel her?
Now it is long time, ma'am, that I have forgotten counseling for induction of labor. But however, yes, all IVF pregnancies does not mean it should be an elective section. So that is one thing which we all of us have to understand. But yes, we do have a low threshold for cesarean because at the end of the day, we should have a healthy baby and a healthy mother. So then it is the obstetrician who has to take a call along with the counseling with the family members, is what I feel.
Yeah. Okay. So Vikas,
I would involve the pediatrician also in the counseling.
no, he
Because,
will. We'll tackle the pediatrician. He will not go. He has got the last word. Okay.
No, in counseling itself, because, suppose it's an elective section for some reason, or she lands up in an emergency section and that baby has some transient epiphany of newborn needs an NICU. And if you have said that it's 38 weeks, baby should do well, should not have any problem, it goes contrary to what is happening to the baby after delivery. Therefore, I would involve the pediatrician in the counseling right at the beginning.
So the
Because the
question
need
goes, ma'am, how often you meet such couples before planned births to explain the anticipated problems? The question is there for the pediatrician. It's there.
So, Vikas, now, having been there, I'm sure you don't want to see the baby only when it's out. You want to be there in the journey with the mother and the baby. So, how often would you actually talk to the mother through the journey of her pregnancy and also be there to talk to her in the process of labor, particularly with this diabetes and this hypertension? Because these diabetic moms are a little more premature compared to the normal ones. So, how often do you talk to them and what would you counsel them differently from what an obstetrician would counsel? Would you like to meet together? You would like to meet them alone? Would you talk to them about the breastfeeding part of it and the whole lot?
Yes, ma'am. It actually basically depends on how severe we are anticipating the issues and are we expecting the child to have any issues. So in this case, I mean, most of the 99% of the time, I'm actually thanking my stars for having good obstetric colleagues, for taking care of everything before they actually. In fact, actually, they don't come to us at all. And this is what we actually want. I mean, everybody thinks neonatologists would prefer to have babies. No, we don't want. We want to see them, by the mother side, and we never want to see them in the neonatal unit at all. Having said this, it again depends on the severity. Now, if you're looking at this particular case, this child, this baby would hardly need any monitoring other than the sugar monitoring or looking out for hyperbilirubinemia, setting in early, and basically ensuring good adequate breastfeeding, for which we have good lactation counselors. And sometimes when we actually pediatricians talk to the mothers, encourage them, counsel them, and go on with getting good breastfeeding. And that is all what we do, other than no involvement. But if you just take it a little, a notch down or a notch up, either ways, whatever, how you want to put it. If you look at, let's say this baby comes out a little early, or anticipated to be early, premature IUGR bad combination, this is what is going to land the baby in trouble. What we then is lucky for us to have good pediatric obstetric colleagues who actually communicate to us early on, and this is where I actually sit with the parents, and actually we have a dedicated slot. So it's not like you're in a busy clinic and you want to just say 2 minutes, look, we'll take care of you, whatever it is. That doesn't work. What works best is for them to be reassured. One, listen to obstetrician, what the obstetrician has beforehand said to the parent of how the pregnancy is progressing, what might be a premature interruption to the pregnancy. If that is the case, then to reassure the parents that look, we are there as a team, we will be there to support. First. Second thing is they will have a lot of questions regarding what happens if the baby comes early, how bad is it going to be, how long the baby is going to stay in the neonatal unit. And these are the kind of questions that usually come across. But I would say, in my experience, it's been almost 50-50. 50% of the times they actually never end up with us. I've had one experience which I always will remember is when I went to a mother expecting preterm delivery, and I said, "Look, this is what we're going to do as a team. We're going to be there. We're going to do everything." And the mother said, "How sure are you, doctor, that this is going to come out today, tomorrow?" You're actually stressing me out by saying all this. So then actually, this happened quite a number of years back, and this actually changed my the way I counsel the parents is actually say that, look, I wish the first thing, and actually the opening sentence I say is, I've just come to say hi, and I am not going to see, hopefully not going to see you again till 37 weeks in the postnatal ward. That's the first sentence itself actually puts them at ease and calm and infrequently for them to listen to what I'm about to say next. And second, then the next thing is I will say is, look, if things go wrong, we're there. Hope it doesn't go wrong. But if the things go wrong, we are there. We'll look after. We'll be there. Actually, they are much reassured with that because 50% of the time we don't end up seeing these babies at all. Because you guys are monitoring so much, doing so many things, and yes, inevitable things happen. But most of the times, if the effort that you guys put in and carry forward this pregnancy to the end, I don't see them a lot. And that's very reassuring. But if it comes to that, then we actually, and there are some instances when you know it's going to happen, and you know that they're going to have a preterm baby, IMG baby, which is not need to go and probably be there in the unit for 6 weeks, 10 weeks. That time we actually take the mother to the unit and actually show them. We show them babies who have been there, who have grown up, and in our unit we have babies of different gestations, from extreme preterms to almost nearing discharge who have grown well. And we show them, look, this is not something that you need to be scared of. If they come out very early, very small, don't worry. This is a baby here who was like that, but who has come out very nice. Who's going to go home maybe in the next week or two, or just about to discharge. We always have babies like that. For them, it's very reassuring, and it does help them. One more thing we have is we at our hospital chain we have something called as Prepare. This is a group where the parents just delivered an extremely little babies or babies that are going to stay in the unit. We actually make them speak with parents who have graduated out of neonatal. So they, when the parents speak to these parents, new parents, and then tell them what their experiences have been, the support has been in the journey. This is very, very reassuring to these parents. So this kind of various ways which we try to help them. But like I said, 50% of the time, actually more than that, we get to see the parents again, which is actually very good because we see them in most.
Yes, but if I were to say an ideal time would be once in the third trimester and at delivery, so at least twice.
Twice. Most of the times it happens is third trimester before delivery. Definitely, if you are anticipating issues, if you have, let's say, committed to something, it's good for us to know because we will always be there and we are always in our place. Are very supportive and actually work like a team. So it should be that for the parent, they may be two doctors, but it's actually from one to another. It's seamless. It's like a movie. So there should be no interruption.
Seamless transition.
Yeah, absolutely.
Yeah.
Absolutely.
So with that, there's a seamless time up now, and I think we'll have to stop. And all good things come to an end. And we are just the string that ties the luminaries together. And we will sign off, Dr. Tarakeshwari and myself. And we thank our panelists for having done such a wonderful job. Thank you very much.